Resource.
Into one. Perfect.
Handover.
Yeah, no,
A little bit of bruising coming out on his eyes, indicative of possible base of skull fracture.
We'll take her for a CT head still.
Yeah.
The thing number one really is getting you out of pain.
We'll give him some blood and then we'll get to scan as soon as we can now to get the answer as to where he may be bleeding. This chap's deteriorated now.
He may end up having life-threatening arrhythmias. It looks like you're having a heart attack.
Hello, trauma pre-alert. Okay.
I'll put the bleep out. Helicopter landing, ETA 1845. Get the trauma bay ready for me then.
No, I don't want him to have his warfarin. So we've had most of handover, haven't we?
So it's a trauma alert, category 1.
We have a 17-year-old male been out mountain biking and crashed. The issues that we have is he's sustained a head injury, he's been knocked out, and there's also concern about an injury to his pelvis and to one of his legs. Into one. If you can leave your blizzard and then just take the scoop across.
What we'll do is just let's get that right out.
Okay, we will do that on 3. 1, 2, and 3.
This lad is called Dudley. He's 17 years old.
Okay.
At 14:50 approximately this afternoon, he's been just north of Wrexham on a mountain bike track, wearing a helmet.
Yeah.
And he's come off the bike on a hill and fallen down. He's then lost consciousness for about 10 minutes. There was some bypassers who thought he might have been seizing and having some sort of posturing. Taken quite a long time to extricate him from there, so SAR winched him from that location and brought him down to us. Injury pattern-wise, he's got signs of head injury, facial injury and lip swelling.
Yeah.
He's also got a little bit of bruising coming out on his eyes, indicative of possible base of skull fracture.
Okay.
And he's got a splint that was placed on the mountain.
Yeah.
Okay?
Do we know anything medical history-wise? Sorry to...
We don't know anything more about him, sadly.
Yeah, no.
All we know his name is Dougie. That's all we managed to get.
Braz, can we start with primary survey?
17-year-old male, intubated, ventilated, on his anterior. His crepitus, chest, equally bilaterally. Pelvis, got a binder on.
Yeah. Any obvious rib fractures on palpation?
No, he's got no crepitus.
Okay. So, actions-wise, you have to order a full trauma pan scan.
Yeah.
Should we get the scoop split? And then can we look at getting access and bloods?
Just say that.
Time is absolutely crucial. We're concerned about injuries in his head, in his pelvis, and his lower limbs, but really we don't know the extent and the severity of those injuries. The unknown thing is what's going to kill that patient.
And 3.
Oh, we're stuck. I just want the wristband.
I have the drug spray, please.
Emergented fib.
No, on chin, please. Centered chin, thank you.
We'll also got the fractures.
Yeah.
So you can see those there. Might be a small subdural.
Small subdural.
A subdural bleed on the brain is blood within the skull. The inside volume of the skull is fixed, and if those bleeds continue, they will then put pressure on the brain, which at its worst can be life-threatening.
Can take him off the table, guys.
Injury-wise, he has a pelvic fracture, and the orthopedic team are having a look at it to see what management needs to happen for that. So unfortunately, he has a bleed on the brain, for which we're going to take advice from our neurosurgeons.
Neurosurgeons are on the phone.
Ah, perfect.
Okay, go for CT. I'll label the bloods and see what's back. Yeah, okay, thank you.
Hello, it's Paul Hancock, the consultant trauma team leader. He is 17, been out mountain biking, crashed his mountain bike. It sounds like at speed, coming downhill. Question from your side, it looked like there was small subdural bleeding. Yeah. Brilliant. Resus number 1. All right, see you in. Bye.
I'm Bobby. I'm the neurosurgery registrar on call tonight. Neurosurgery plays a vital role within the major trauma unit.
He's got some transverse process fractures. He's been cardiovascularly stable.
Has he got any chest and stuff injuries?
Former but what's not back.
When we look at a brain bleed in a young patient, we know there won't be much space in the brain. They're more susceptible to these very sensitive rises in pressure. This is not something that we can wait on. Let me look through the scans. I'll be back shortly. Yep. The pressure that it's exerting on the sensitive structures within the brain can cause death. He's in a coma induced by the medications that we're giving him. As a result, we can't assess him. So even though he has a head injury, we need to be able to know what's going on inside the head. And the way in which we assess that is to insert a probe.
That much, is it?
Yeah, that tightens it.
We're going to drill a hole in his head and place the intracranial pressure monitoring bolt device in. So if the pressure were to go up too high, it's possible he may need a surgery or other medical treatment to try and reduce the pressure within his brain. Right.
That's the one lick. Straight down. Look at that. Straight down. Okay, I've got the head.
You got the head?
Just perpendicular, you got it?
That fluid that's coming out is the brain fluid, and it's coming out quite quickly, which shows some pressure in the brain.
Pop that on the side. So get it at 4 centimeters. Put your finger at 4 and then secure that. Okay, so a moment of truth. We should have a number on the screen there. He's kept asleep, so we need a ICP less than 22, and that's what we aim for. And that is reading. Okay, fine. And we're just.
That's 15.
He's going to be kept asleep tonight. We'll aim to wean the sedation in the morning, see how much movement he gains, so that way we can assess him a bit further. The pressure inside the head can fluctuate at any given time, so the next 24 hours are critical.
Eight minutes. Okay, 8 minutes. And are you happy going to red resus?
Hello, resource Stoke. When they've been to CT, into ambulance assessment, have you got a patient that can move out? Because there's a space around the back now for another one.
Daniel, we're just going to pop a drip in, okay?
Got a trauma alert, adult male, 80 years, 80.
Head-on collision on a A51.
So if we pull 5 out, we got another Belmont.
3, waiting CT results.
New North South resource. Yeah. Okay. Yeah. Got an 80-year-old gent, driver of a car and an RTC. We've got a head injury and pelvic injury with a GCS of 13.
There's a gentleman coming in following a road traffic collision who may have head and pelvic injuries, whose conscious level is less than it should be and whose heart rate is faster than it should be.
15 minutes.
So it sounds like a husband and wife, they're both coming as traumas.
Thanks, bye-bye.
But potentially the husband's a little bit sicker, so he's going to take priority.
Sorry. Just raise the bed.
I can do that.
Sorry. Raise the bed.
This is Joe Pegstock. He's an 80-year-old gentleman, approximately an hour and a half ago now. He was a driver of a utility Yaris, probably. We'd clipped some slowing cars on one side of the road. made him spin into the oncoming traffic and got T-boned on the driver's side at high speed. Blood around his nose, grazing to his right lower quadrant, as well as probable right dislocated hip, I imagine, from dashboard. Pulses are intact in his feet. Interventions, bilateral IV access. He's had a gram of TXA, 2.5 of morphine, 1.2 grams of augmentin for his head. He's got a binder, been immobilised, has a dressing there. As we moved him from the car into the ambulance, he dropped his GCS a bit, became confused. And we struggled to get a decent blood pressure on that cuff throughout.
We have had the second patient from that he rang through.
His wife.
Coming in 15 minutes, head lacerations, GCS 13 out of 15.
There's a combination of factors that make it more tricky sometimes when assessing elderly patients with trauma.
Joe, where's the pain? In your back? Okay, come here, you're doing ever so well.
He's at risk of different things, I would say, than other younger patients. Maybe on blood-thinning medication, for example, that may make any bleeding that's going to happen worse. He's more susceptible for certain things, such as rib fractures, spinal injuries, those kind of things. From the outset, it's already in your mind that this might be more life-threatening.
Can you tell me your name, please? Joseph Fixter. Huh? Joseph Fixter. Okay, Joseph Fixter. Do you know where you are at the moment? Yeah. Okay, where are you? Hospital.
We'll need some more information about his general health. His wife is here, and while she's got injuries herself, she would be able to answer those questions. Hello, it's me again, love. This chap's deteriorated. I'll ring you again before we're ready to come.
Stay still, Joe, stay still.
His blood pressure dropped significantly, which would suggest that he's bleeding. Trying to get him a little bit more stable, if possible, before we go to the CT scanner. We don't want to delay that too much because we need to find out what's causing him to be unstable in the first place and what we need to do about it. Did we get a temperature on him when we... No, so we can do that as well, make sure he's warm enough.
I don't know, Joe, eh? Didn't expect to be in here with us, did you, hey, darling?
Okay, can we get some morphine, please?
If he's losing fluid, he'll be losing blood. His blood pressure when he came in looked artificially and spuriously high, whereas now it's realistically low, I think. I can't feel a decent radial pulse, which would suggest that his blood pressure is low.
We got a warming blanket that we can put on.
His blood pressure's come up with a bit of fluid. The scanner's ready.
Yeah.
Let's go.
Cardiac wire.
Slide. Ready, steady, slide.
Okay, Joe, where's that hurting you, my love?
Your back.
Your back, okay. Joe, we're just giving you some more painkillers now, my love, okay? I've seen your good lady wife, all right? We'll be looking after her as well, so don't you worry about her.
Yeah? Good. I'm going to go into the room now where we see all the images, okay? You're going to be on here on your own, okay? You'll only be for a few minutes. When's Joe picked up?
Breathe in and hold your breath. Breathe normal.
So he's had a total hip replacement in the past. Looks as if there's a fracture that's sitting beneath the prosthesis. The fracture itself, to be honest, in a gentleman of his age is a major injury for him. Okay, we'll get him off, please.
She's got rib fractures.
She's got right side rib fractures there.
Okay.
Can't see any on the left.
But definitely on the right,
Definitely
yeah.
on the right. They're displaced as well.
And they're displaced, okay. That's probably why she's getting that pain, and her oxygen levels are probably dropped because of the rib fractures, because she can't expand her lungs properly.
The chest wall is just a bit abnormal on the
Right, okay.
I think that's an intra-abdominal extraperitoneal hematoma.
I'll let the consultant know as well. Thank you ever so much.
Joe, your son's here, ducky. Right, put your head right over the top, Andrew, okay?
You're all right. All right, you're in best place. And Mum's not too bad, they've said, so we're okay there. You just keep yourself breathing and, you know. They were coming to visit me, and when they'd not arrived, I started ringing the phone. And the police officer answered the phone and told me what had happened and where they were. So, obviously, I've made the best of getting here as I can.
All right.
I'm here.
Okay.
All right, mate, come on.
Oh,
Just bang yourself up a bit, haven't you, that's all. We don't know whether my sister can get here or not. We'll all muck in and we'll rally around and band together and help them get better.
Right. Joe? I'm Anne-Marie here, I'm one of the consultants. Yeah. It looks like you've had a total hip replacement on this right-hand side, is that right?
Yeah.
So you've got a fracture to your leg just below that, and also in the pelvis where the ball and socket has gone through the bones around your pelvis, because the metal works much stronger than your bones. We need to figure out with the orthopedic team what we need to do to try and fix those things for you.
Okay.
All right? You yell at us when you need some painkillers. We've got a cupboard full.
Okay.
All right? I'm just going to go and see your wife. I'll update her on you, and then I'll come back and tell you how she is as well, all right? Traumas aren't always predictable. With elderly patients, the complication rate is likely to be higher, and so the outcome may be much worse. So the x-rays of your wrist and your leg are all okay. I haven't looked at the final report of your scan at the moment, but I just wanted to have a feel of your tummy, if that's all right. Are you sure that's all right?
Yeah, that's
yeah.
right. I have to have an hearing aid. I am a bit deaf.
That's all right. I mumble. My mum tells me I mumble all the time. I actually think she needs a hearing aid, but I won't have that conversation. No? That's brilliant.
So is that all right?
That's good. So I'm just going to have a look at the report now. What I do know is that you have fractured your breastbone or your sternum, and that's the bit that we thought was fractured because of where you got the pain. And you've got some rib fractures as well. So I'm just going to have a look at what the X-ray doctor has said about all the different bits. Is that all right?
That's fine.
How's your pain at the moment? Do you need any more painkillers?
Yes, it's it's just
here.
Yeah.
Okay. Can roll you in next door maybe so you can have a quick chat with Joe. All right.
Yeah.
Get you some painkillers in the meantime. Yeah. All right.
Water, please, to green resource, thank you.
So she's got a sternal fracture, bilateral rib fractures, pelvic fracture, and potentially a bowel injury. The bowel injury may require an operation, and the pelvic injury may limit her ability to get up and walk around. So all of those things added together are significant for somebody of any age, so definitely for somebody of 76 years. So what was originally thought to be just a sternal fracture has actually turned out to be a lot more. She's obviously hiding lots of those injuries, so it's a good job we scanned the rest of it, really.
No swearing, you two.
Are you okay? I'm here.
When we put the catheter tube into his bladder, because he was finding it difficult to pass water, we found fresh blood in his urine. So he's been back to have a scan to look in particular detail at his kidneys, his bladder, and the water pipe that comes out from his bladder. It's going to be a long road ahead for both of them, I think. Both of them have significant injuries in multiple areas, that some of which will need significant operations, rib fixation, that kind of thing. So it's the start of a long road for them. It's too early to tell how they'll recover and what the long-term effects will be, but there's significant injuries for both of them, I would say.
Can we have another porter, please, to green resource? Thank you.
Rollercoaster resource can I help?
6-year-old generally unwell, respiratory rate of 50, blood pressure of 60.
Can you do me any of these?
The patient is a 74-year-old gentleman who's been admitted as an emergency. So we've taken some biopsies, and biopsies have confirmed that it is indeed the cancer of the stomach. Cancer usually doesn't kill people quickly, but in this situation, when cancer is blocking the stomach, he's essentially been starved. That turns it into a critical situation for Vance. Hello, good to see you.
Good to see you.
How are you feeling?
I'm feeling good.
Can I perch on the end of your chair? So, what I'm hoping to be able to achieve today is an operation that will remove probably all of your stomach. So that you can eat again. We will use a loop of your small bowel, bring that up, and join that up to the bottom of your food pipe, the esophagus here.
All right.
Okay?
Yep.
So your steak and chips can go in that way.
Yeah.
Okay? And then the liver, the bile, and all the juices come in the other way.
Right.
And then they join together again back to normal here.
Right.
Okay?
Yeah.
Good luck.
Good luck. And good luck to me.
Sure. We'll look after you. We'll look after you.
I know we will.
I'll see you there. All right. See you.
I've had a shower this morning. Actually.
Yes, I have, yeah.
Right, I'll see you when you come back.
All right then.
All the best.
Thank you very much. And I'm hoping for the best. And I came in as fit as a fiddle. I told them all the symptoms and they said, right, you're staying in. Obviously now we know it's a cancer. Until they get in there, we don't know how far it's spread.
You're all right.
Yeah. I'm just thinking positive. That's all I can do.
All of these operations, all of them carry a certain degree of risk. There is a degree of uncertainty and a degree of unknown as to whether we can even achieve what we need to achieve. First of all, we're going to make a cut in his umbilicus, his tummy button, and distend the abdominal cavity full of gas so that we can see there's some space in there, and put a camera inside. As long as there's no significant spread outside the stomach, we will then proceed to an operation to take the stomach out. The gas on, please. Okay, can I have a top lights off, please, for a sec? No, it's okay, not for this. For the squint. Okay, so far so good. Yeah. It's all a bit thicker now, but there's no peritoneal disease. Yeah, that's very good for him. Yeah, absolutely. Absolutely. So the good news for him is that we're going to proceed to resect. Okay, there's nothing inside, there's no spread. Okay, so the stacker can go. We've done the bit where we were looking inside his peritoneum. So we've done the laparoscopy bit. There's no sign of any spread of the cancer outside where we know it is already. So that's good in terms of we can go for the big operation, which is cut straight down the middle, take the stomach out.
Small ones first.
Right, good. Top lights on, please. Everybody ready? Shall we go? When you are setting out upon an operation that you know is going to last for 8 or 9 hours, and you go through scenarios in your mind, imagine this scenario happens, how am I going to deal with it? imagine this, imagine that. So you kind of run through stuff and imagine yourself dealing with that scenario, should it arise. Just push down the liver, fingers on the liver. Oh, that's nasty, that is. That is nasty. Don't know if it's going to come out. Oh, Christ. Come easily, look. It's just saves time, isn't it? Here's the liver here, here's the stomach, and you can see this colour change here. This is where the cancer is. Horrible tumour. Rather not after resecting your colon. That's the sarcoidosis. It's not a very, it's an untenable position, isn't it? The more we get into this tumour, the more it looks bad. Impact, please. Thank you. So it's kind of stuck, there's involvement of various structures that live close to the stomach, like the gallbladder. My concern is that we're not going to take it off the duodenum. It's not going to be able to come away from the duodenum. No point doing that if you can't get the primary tumour out. Yeah. So there's a major concern here, which is the ability to remove the stomach. It's completely stuck at the back. It's stuck to the structures around the duodenum, around the liver. So I'm just going to keep going, but I'm a bit concerned. It's not good. Is Mr. Batts around, right?
Yeah, I can call him. He's on call.
Just at some point, I think we'll ask him to come in and have a look.
Gallbladder's stuck on it.
Gallbladder's stuck, and you know, all sorts.
No, in the pathology.
There are aspects of the operation that you definitely feel the pressure. Yeah, gallbladder's involved with cancer. At that point, you are acutely aware of the limitations and the consequences of that for your patient. Get this down first, and then we'll have an idea about the extent of where this tumour goes. They are putting a huge amount of trust and faith in you. They're looking to you, trusting you with their life. I mean, even if I can get across it, but the thing is you can't rely on that not to just fall apart. If you're cutting through tumour, forget it. Or just so we can eat again, but I mean, the other thing is if we can't resect, we're just discussing other palliative measures right now. Foot on a stick, please. Just push that down now. But, oh, there's no chance. Let's ask Mr. Batt for an opinion. Thanks,
Anatomically obstructed.
Hello.
So you can get past.
Hi, Anand. So there's a chap who's come in, he's got a gastric outlet obstruction, but it's extending all the way around the duodenum. And it's involving the fundus of the gallbladder, which is stuck to where the cancer is. But I don't want to be chopping through cancer, you know? And I just don't know, I'm not sure there's any merit in keeping on going because I don't know what's at the back. Renal is free. He could come and take over from me just for 5 minutes if you wanted to just come and have a quick look. That would be ideal if you could, Anand. Is that all right? Brilliant. Thanks, Anand. See you soon. Yeah, he's in MDT. I've just been talking to my colleague, Mr. Batt, who is a hepatobiliary surgeon. So he does these operations on the duodenum and the pancreas to resect the duodenum and the pancreas. And really, it's just to make sure that we've explored every avenue for this chap and that we've left no stone unturned. It's always useful in this situation to get a second opinion from a consultant colleague, and he'd be gracious enough to come and just have a quick look and tell us what he thinks. So this is the stomach. It is hugely distended. It goes on forever and ever and ever up there, but the colour of it is a relatively normal looking colour. But you come down here and you see the colour change there, but this discoloration is where the cancer starts. And then it's involving all of this area here. And this here is a gallbladder here, and that's all stuck with cancer as well, I'm afraid. Chemo would give him a survival benefit. It was not going to cure him of his cancer, but it can, as long as he responds to the chemotherapy, then he'll definitely get a survival benefit. More time, a few more months. Oh, hi. Anand, hi. Come in. Thanks so much for coming. I'm so sorry to trouble you. I don't know if you can see better this side or this side, but so cancer starts there, comes down all the way down here. Gallbladder stuck up there. Can you see that? Yeah. So that's, you can see the nodules there on the. Stop. Okay, I agree. Thank you, Anand. Thanks very much. Thanks, Sean. So obviously that's disappointing, but we know we've explored every possibility and we've made sure. Very important to know when to stop. The problem was actually extension of the tumour around the corner. It's also the tumour's gone beyond that and grown into the next organ, the duodenum, and even included the gallbladder, which is also stuck to the cancer. What's happening now is that we're now identifying a loop of healthy bowel further downstream the small bowel, bring a loop up onto the skin, and a tube goes through the skin, through the abdominal wall, into the bowel, and is available there. And he'll go home with that as a route by which he can have nutrition. Because obviously, his stomach is still there, his stomach's still not going to work. So we have to provide him with a means to have nutrition, otherwise he'll never make, never make any progress. The most difficult thing is having to explain a situation to a patient or their loved ones. Hello, Mrs. Redden. Oliver Priest calling from the Royal Stoke. Hello, how are you? Are you not in the hospital by any chance, are you? No problem. So I've just finished in theatre. I'm afraid it's not good news. So we tried our best, but I'm afraid to say we couldn't take out the stomach. The cancer has spread to beyond the stomach and made it not possible to remove it. It was stuck to all the structures around the stomach and beyond the stomach. So I'm afraid he still has the cancer there. He still has his stomach there. What we've done instead is we've put a new feeding tube down into the bowel that comes out onto the skin. Obviously, when he's well enough, he can go home. And then he'll have to see the cancer specialist, the oncology team, and discuss some chemotherapy. So I'm really sorry we couldn't achieve what we wanted to achieve today. Okay, all the best. I'll speak to you soon. Take care. Bye.
Hi, resource.
Now there's bloods on the side for this one. The equipment in there, can we swap them?
Bag here? Yeah. Yeah, he's reverted, you can go.
We've got stroke, RTC and the trauma that's coming in.
Do you want the trauma going into this one?
So we'll put 6.
His abs are all fine. Cool, let's see that. It seems that there's a gentleman who's got chest pain and the tracing of his heart looks as if he may be having a heart attack.
17:43, 13 minutes. Where is Belmont? Do we know?
It's in the holding bay.
Okay, but they're going to hold.
But they're going to hold, okay?
We've got Elton, who is 49 years of age. Since 6:30 this morning, Elton was woken up by a central chest pain, radiating to the left arm. Elton said palpation, stretching, breathing, no effect. Described as crushing in nature. Has had 10 milligrams of morphine.
Does your wife know you're here? Yes, she does.
Hi, sir. My name is Paul. I'm one of the cardiology doctors. Nice to meet you. Where is the pain? Okay, does it go anywhere else?
Not really, no.
So when did the pain start?
They said about 6:30 this morning, and then it gradually started getting a bit worse, but I remember I didn't know really what to do with myself. I couldn't get comfortable, and I remember my dad was like that when he had a heart attack.
What age did he have?
He had a heart attack at 42, and he passed away a week on Sunday.
Oh, then, okay.
Which we assume was a heart attack.
Oh, I'm sorry, sir. Okay. So it looks like you're having a heart attack. A heart attack happens when one of the arteries supplying your heart blocks. It looks like the artery supplying the right side of the heart is probably blocking. So the treatment would be to take it to the Cath lab to do a procedure to open it up. So we would go from the wrist. So there's an artery here. We can get in it, pass special wires and catheters into your heart, open it up with balloons and stents, and then you'll be on medication for the rest of your life, okay? So you've got 1 to 2% chance of having further heart attacks, stroke, or you not making it through the procedure during the procedure. Overall, if we don't do the procedure, the risks are much higher. So I think we need to go ahead. Is that okay?
Yeah.
Thanks. Longer we wait, the more damage the heart suffers. So everything needs to happen as quickly as possible.
What is your pain, Nelly?
Elton Wood, we're going to give you some medication, okay?
I'm going to give Nicky a ring now and just explain to her what's going on, and I'll see you when you get back. Okay? Somebody give me a hand round.
The risks if we don't do it immediately is that the patient hearts will suffer long-term damage. And in the short term, he may end up having life-threatening arrhythmias. We should do it within the 120 minutes of him calling for the ambulance.
How are you doing? Where's your pain? Let's go with a left 3-5 diagnostic and then a right 4-5.
I'm going to put a little plastic tube in, and then we can put the rest of our plastic tubes in through that. And it takes us about 5 minutes to get some pictures of your heart arteries. I'm going to expect to find a blockage to the vessel supplying the bottom of your heart. Cocktail. Big flush there, please. Big flush. Yes. It's going to feel very funny in your wrist. Combination of cold and warm at the same time, okay?
Where a patient suffers from an abrupt blockage in one of the heart arteries, the segment of muscle will actually die.
I'll just get you to take a bit of a breath in there for a moment. Big breath in.
If this is not treated, they can be profoundly unwell and are literally on the brink of passing away within a couple of seconds.
Okay, so you got a blocked artery as we expected. Let's go with the sample. We're going to open it up for you now. Squish that. So it's fine. Okay, are you okay? Got the flow back, And we're going to put in a scaffolding device called a stent. It's a bit like an expensive spring. And what we do is squeeze it open and it stays open. 14. We're squeezing the stent in now, Elton. It's going fine.
14.
So, Elton, I'm sure this is not the way you would wish to spend a Friday morning, but how are you doing? Are you okay? Good man, well done. Once again, up to 18.
18.
Pull that wire out of the distal bed. You're going to be fine. Your ECG's settled down completely, and I'm sure you'll end up with no significant loss of the horsepower of your engine, which is really what this is all about.
Matt, could you just knock the ether off for me? Yes, please.
Having opened up the vessel, we've now restored the blood supply. It's likely that he'll make an excellent recovery, and everything from here on is to prevent further problems in the future, and I think we can do exactly that and get this young man, which is, to full normal activity.
Is there a medically fit bed that she can go to and then go to her eye clinic at 3 o'clock?
Little shards of glass on her. We've tried to clean as much as we can.
We're going to need to go with a pink cannula and a left antecubital fossa. When a specialty team has taken ownership to the patient, it doesn't mean that you don't think about them anymore. It doesn't mean that you don't think about what you may or may not have done differently if the same thing were to happen again. And it certainly doesn't mean that you don't think about them in terms of what outcome they may have, how that may be affecting their family. Is there anything on the card for this stabbing yet? There are certain patients that stick with you. You have to move on to the next patient. Hello, hello.
That's on the way. What do you want?
So he said he's had a stent fitted, and I guess we need to wait to hear if anything else needs doing, I think. Relax a bit now.
Would somebody mind just booking him in, just because I need to go and get more blood trace, man? Is that all right?
We've got a stabbing to the chest coming into resus. Do you want to come and give us a hand?
At the minute, everything's sort of fused together.
It wasn't the news any of us wanted, really.
No. So what they're doing, building me up again, possibly chemo at that point. It's a waiting game. And I just hope something will come positive. She's my positivity as well.
Got to stay positive together.